Hi, everybody. Good evening. This is Hermann speaking from Berlin. I'm happy to present this live stream today, live from Berlin. It's January the 3rd in 2025, so it's a very new year, and we thought we are bringing some new cases for you to discover and to learn. And we have a collection of cases that you can watch on the screen, that you can also access on the on your device, on your mobile device, or on your laptop. So please, for now, if you are here and if you are watching from another city, just comment in the comments where you are from. That would be nice. So we also have our assistant online, Asif. He will appear eventually on screen. And we also have a special guest from UK today, and we will bring him on stage after the first case. So if you have any questions, you can always use the chat box. And of course, I'm very happy to hear your thoughts on the cases that I will present. And of course, I also will answer your questions after each case. So what do we have? Here are the cases that I have prepared. So in total, there are 6 cases that I will go through. It will take roughly 1 hour. We have an additional case that will be presented by Dr. Lasker. And thank you, Maximilian, for joining from the north of Germany. It's very nice that you are here on this day, because I think many of us are still on holiday and enjoying the time off between the years. Okay, so let's start the show. I will go into this first case. It's a case with chronic joint disease lasting for many years. If you want to access the cases on your own pace, or if you want to work with the questions, because as you can see, I have included some multiple choice question in almost all of the cases. So of course it would be nice if we could use these questions, and there is the QR link in the top corner, which you can scan now with your phone. And also we have our URL that you can enter, and I will also provide it in the chat box, so you are on the best place to click on the link, and then you can enter the platform as you like. So here is the link that you hopefully can click. And we also have from Belgium Dr. Lavintella with a nice profile pic. I also recently adopted a cat, so I can connect very nicely with you from Brussels. So nice that you are here. And if you want, you can enjoy the cases in full resolution on your own screen. And if not, I will show everything. Okay, so let's start. We have here the live data. That would be nice. Yeah, that needs to be shifted to another monitor to see what's going on. Yeah, very nice. So okay, so we have the QR code, we have the link, and we start over. So we have this first case, and this is a male patient, a 60-year-old patient. And you can see that the patient has been suffering from joint pain for more than 20 years. Initially, he was seen by the GP, and he administered cortisone and also NSAIDs, and then it did not go better. So the patient went to a rheumatology center and was seen by a specialist. So they started with methotrexate therapy, which is usually the first step. and in most of the patients, this medication is tolerated well, but here there were some side effects, and the methotrexate therapy had to be stopped. And further in the line, of course, more intense treatment has been done with TNF blockers. You know, these are around for about 20 years now, and they were really a very good solution for these patients which who could not be treated really good in former years. However, they only give good results, maybe in about 70 to 80%, and some patients are still not reacting to the TNF blockers and get destructions of the joints. So on clinical examination, we could see severe swelling of the joints and also pain, and also there was ulnar deviation of the fingers. So here we see this X-ray. Of course, it would be nice to put both X-rays together, and we can split the screen, and we put the right hand next to the left hand. It's always good to compare the right and the left hand, and what you can see here is a typical pattern of a patient with rheumatoid arthritis. And we have this deviation of the fingers, which is to the ulnar side, and this is called the ulnar deviation. We have here the ulnar, this is the radius, and this is how the sides are called on the hands. When we can see that these joints, they have a wrong axis on the MCP joints, and also here, and it's a symmetrical distribution. So what else can we see? We see there are some defects here. There are some erosions at the MCP joints on the second ray, also on the third ray. If you go very close, you can see that that this contour, that is okay. Maybe there's some small defect over here. Also here, this contour is okay, but here we see some lucency. We see also some destruction over here. We can see the destruction and cystic changes over here, and also there's a large defect over here. So we call this an erosion. And as it is on the lateral side of the joint, we call it a marginal erosion. That means it's on the lateral aspect of the joint, and we can see that the central part of the joint that we can see here is well preserved. So that's typical for rheumatoid arthritis and other forms of arthritis, that the central part of the joint is well preserved. On the other hand, we see the similar changes. We see the large erosions growing into the bone. We see an erosion here at the third metacarpal phalangeal joint, and not sure if the fourth and the fifth joints are also affected. So I don't see any of you on the platform until now, so I will guess that nobody will answer this question. Of course, that would be really nice if at least some of you would participate and would challenge themselves. So here the question is, what causes the ulnar deviation? So I already explained what it is, but how is it created? How is it happening? And we have different options. So it could be due to severe destruction of the joint capsules, synovitis, due to severe destruction of the tendon sheaths, tenosynovitis. The main reason could also be due to erosions, which we definitely have. And also it could be due to soft tissue edema and bone marrow edema and all the stuff that we can see on MRI, and therefore we have at the end these ulnar deviations. So to make it clear, it is due to the tendon sheaths. So the second answer is the right answer, severe destruction of the tendon sheaths. That means if you have tenosynovitis, of course you have inflammation in the tendon sheath, so the sheath itself gets destroyed after a while, and then there's no track that the tendon can use when the finger is bended, and then therefore the tendons pull the finger to the ulnar side, because the muscles on the ulnar side, they have a bit more strength than on the radial side. Therefore, you need a destroyed tendon sheath in order to have ulnar deviation. That means the ulnar deviation is one of the later changes in rheumatoid arthritis development. Okay, so that is also nicely also written here in this learning text. So if you watch this live stream as a recording, you can always access the platform and learn about ulnar deviations. Are there any questions so far from your side about rheumatoid arthritis and deformities of the fingers? So if that is not the case, I will ask Imran, and I will ask our assistant Asif if everything is on the good side. So here we have all of us. Hello Asif, hello Imran.
Hi.
Very nice.
Thank you for having me.
This time also with good sound. So thank you, Asif, for helping the technical side. And thank you, Imran, for being so kind to just be here and present a case. So you are from the UK, I think, in the greater area of London.
That's right. Yeah.
Are you working? And
yeah.
So tell us a little bit about your professional life. So what brings you to the field of MSK?
So I am a consultant radiologist in London, and I always found MSK very interesting. I did a small amount of time at Royal National Orthopaedic Hospital under Dr. Asif Safieddine, who some of you may know. Unfortunately, he passed away a couple of years ago now, but he became a very good friend and a big inspiration for me to do musculoskeletal radiology. He was very into tumors, and then I just kind of didn't have the heart for tumors after a while. I just thought it's not really something I'm interested in. So I've ended up doing a lot more to do with the trauma side and that kind of thing. So and yeah, I guess I also like to do teaching as well, which is why I ended up coming here, because I enjoyed Dr. K's teaching, and I've now learned something very new. I didn't know about the tendons pulling the fingers that way because of the erosive changes. So yes, it's really, really fun. Also, how did you hurt your finger, Dr. K? I noticed your middle finger on the right-hand side. It looks like you might have hurt something. The other side.
You see it? This one?
Yeah, the scratch. There's a scratch in the ring.
You are very very good. I fractured my finger many years ago, and it was handled conservatively. And somehow I got bad advice and started too early with movement. So I had to go to ergotherapy to keep it in a good shape. But obviously it was not 100%. So I'm already a disabled one.
Yeah. Oh, for detail. That's how it is.
Okay. So are you able to share your screen and to present?
Yeah, so I will share my screen.
So there's the option to share the entire screen, and then you can select one window or just one part. Wonderful. I see it, and I bring it on, and Asif brings it on, and we are curious to learn what this case is about.
Okay, so this is someone who's come in with a bit of foot pain. Feel free to jump in with what you think is going on, but what we see here is someone's foot. And I know Dr. K has been talking about erosive changes and that kind of thing, but these kind of edges here look pretty good, actually. And the actual articular surface of the first metatarsal head is actually looking very nice as well. And you'll see that the joint spaces are all preserved. There doesn't look like there's any loss of joint space, no subarticular sclerosis or cystic change at all in the big toe anyway. Maybe there's a slight bit of angulation this way, so maybe a slight bit of a hallux valgus deformity that can be very, very common. I'm sure a lot of people have seen. Sometimes you do want to see whether things are sort of veering off in the right direction, but they all seem to be in a good direction, and that base of that second metatarsal does line up quite nicely with that middle cuneiform. So we're not looking at any sort of ligamentous injury so far. This metatarsal head looks okay. This metatarsal head looks okay. This metatarsal head looks okay. But it's this one that looks very, very abnormal, very, very strange, doesn't it? It looks like there's not much of a metatarsal head that's there. And you can see kind of, it comes this way and then disappears like that. Then you see a little bit of metatarsal head and it disappears like that again. So maybe someone might think it's sort of underlying Freiberg's and fractions, some sort of subchondral fracturing, as I've seen some people write. But it doesn't seem to be at the articular surface, which is here, because this is where you'd normally get the sort of repetitive injuries when people are marching and that kind of thing. This is very much like a big bite out the right side, the more medial side of that metatarsal head. Yeah. And then you may think along the lines of gout and all that kind of thing, but usually gout would affect the big joints, but the rest of the joints look completely fine. I can't see any sort of areas of calcifications anywhere here. So you're kind of stuck. Is this an inflammatory process? And what kind of inflammatory process could it be? Dr. K, Prof. K, would you say gout could be the option on this one based on what you see here?
So based on my initial thoughts, I was in favor of gout, and I was thinking of that's a remarkable case because the first MTP joint is not affected. But of course, we only have one joint affected in this foot. We don't know about the other foot, but there's a big destruction, and there's no. The border is quite it's sharp, so it's like a erosion, and you say it's like a bite out. So we should consider some septic condition in this joint, like septic destruction. But and there's also the demineralization in the base of the basal phalanx. There is some demineralization, but it is not really severe, but you can see it. So my opinion would go into infection if it's not gout, but of course gout would be best.
Yeah, completely right, exactly. And if there's no evidence of any infection, inflammatory markers, no sort of trauma, anything to suggest that there could be an outside process coming in, then undoubtedly gout would definitely be the prime suspect for this one. But the problem is that this first metatarsal is unaffected, and the larger joints, which usually would be the ankle joint, not so easily visible on this, obviously. But the rest of the joints look completely fine. And so I know this is meant to just be a plain film, but just for completion's sake, I have the MRI scan. And so for those that don't know what MRI scans look like, this is a T1 weighted signal, which basically just means you can see fat very bright. So anything that's fat, and so the bones are very fatty, the subcutaneous tissues are very fatty, they should be bright. But if you have areas that don't have any of that brightness, then you know that there's something. Instead of fat, something else has replaced that, right? And a lot of the time, infection can replace that. If it was just fluid on its own, then you wouldn't have so much loss of your T1 fat signal. But this is normal bone. That's normal bone. That's normal subcutaneous tissues. But this is very, very abnormal because you've got complete loss of that sort of fifth metatarsal there. And you've got this very sort of black-looking cortex. Can you see going all the way around like this, around here like this, around like here like this? But the cortex just disappears and almost feels like it's exploded out. Like there's some sort of expansion of this area over here. So this is very much looking like a destructive process. And some of you may have noticed that there is what looks like a destructive process there, maybe there as well. And then coming across, you can see these are the areas that are bright. And on this particular sequence, anything that is bright is going to be fluid. So this is very, very fluidy. But again, there's not much of a metatarsal head located there. This is very fluidy. That's very fluidy as well. And then the subcutaneous tissues can now look very, very bright when actually they should be dark because the fat has been dampened down in this particular image. Oops, no need for the faces here. And then when you look at the side, this is looking like it's kind of gone this way, and there's really not much of a metatarsal head. So when you go back to this one, there is a bit of a metatarsal head, but there's a lot of it's gone on that sort of medial side. But when you come across to this side, it looks like pretty much all of it's gone. So there may be a bit of a time gap between getting this scan and then coming up to getting this scan. And I don't know what it's like in Germany, but sometimes x-rays can take a while to get reported because we just have so many. But there may have been a bit of a delay, and then this ended up becoming a more destroyed than previously. And it essentially is osteomyelitis on this particular image, and it's been very, very aggressive. And interestingly, it's not just affecting this joint. It does seem to be affecting the second and third metatarsals, especially when you look at the X-ray, the MRI scan, which you cannot see on the X-ray. So I hope that was an interesting case from myself. For those that are interested by any chance, this case has been brought from our platform called Radiology Seminars, and it's on a thing called the MSK community for anyone that is finding it difficult to learn about MSK and get into MSK or want to upskill themselves in MSK, we've got an online community. Prof is part of it. We've got a few really big people on here as well. And there's courses on here as well. So big fellowships on the knee and the spine as well for anyone that wants to learn about those things, and also just be part of a network of worldwide radiologists who are interested in musculoskeletal radiology. So yeah, thank you very much. I'll stop presenting my case, and I guess
Yes, thank you. Thank you. That was very informative. So could are you aware of which bacteria was it in the joint?
No, I didn't get any follow-up from this one, so I'm still waiting for any more follow-up for that. But yeah, interesting case, isn't it? I mean, I think the patient was a diabetic from what I remember, and so they probably got a cut or something on the foot and didn't notice.
It happens that we have a patient, we have a lecture on diabetic foot, the destruction next Friday in 1 week, presented by Dr. Marlena Jabbarra from Florida. She's a very dedicated radiologist on foot pathology, and I only can recommend jumping in and listening to her lecture on diabetic foot arthropathy. So Imran, how many members do you now have in your community radiology seminars?
About 60 people at the moment and growing. So yeah, it's been a lot of fun, and it's been updated every day. So I used to be someone who spends a lot of time on Twitter or X, whatever it is, but these days I find it a little bit boring. And so now I just sort of flip through cases every morning, see what's going on, comment, and we have weekly meetings as well. So a lot of interaction, lots of learning to be done, and yeah, it's helped my reporting a lot. I find it very, very useful.
Indeed, I also enjoy your community, and I also enjoy watching others' cases and learning from them, and it's really a good opportunity. So thank you, Imran, for presenting and for challenging me. It was a challenge, in fact.
Yeah.
And if you stay around, would be nice, so we can comment together on the following cases. And I will share my screen again, because we had a question that came from Brussels about the term of ulnar deviation, if it is linked to the ulnar nerve or if it's linked to something else. So you see that's just the naming of the side of the hand, because as the hand, you can of course there is the so-called neutral zero position, where the body is defined on which is lateral and which is medial. Also for the arm, the thumb shows to the outside, so you know the thumb is the lateral side and the small finger is the medial side. But as you can move the hand around, people tend to use to call the sides based on the bones. So we have the radial side and we have the ulnar side. So that is the answer. It's not connected to the ulnar nerve, although of course the ulnar nerve is also more to the ulnar side than to the radial side. But we also have the median nerve, which makes the things even more complicated. Okay, so I will go to my second case, and this case already says that there are some Raynaud's phenomenon and there's dense skin findings. So I always also can encourage you all to go to the platform to answer the questions, because I think this would be really fun. But if not, no problem. I present this case of a 51-year-old woman with Raynaud's phenomenon, and she has subtle acral necrosis and dense skin. So, of course, this pattern is already very suggestive of systemic scleroderma or systemic sclerosis, how you can call the disease. Sometimes it's also called CREST. CREST is related to scleroderma. It's a subset. And maybe I make a lecture later on the differences and common ground of both diseases. And there are also, of course, distinctive findings on X-rays that I wanted to go through together with you. The case is best appreciated if you look at the two sides together. So I split the screen again. I put in the other hand. We have the left hand, the right hand. So we always do it separately. I think I told it, I mentioned it last time, that it's the best quality to have separate X-rays of the hand, not to put them together, which saves maybe 30 seconds, that's true. But it is the better option to have one hand at a time. And you can see that this is the PA view, the posterior anterior view. And what you can already see is that these fingers, they cannot be extended 100%. So they're still flexed, although the patient was asked to put the hand flat on the detector. So this already gives us a sign that there's some problems. Of course, this is not specific to scleroderma. It could be also dupuytren's contracture, or it could be post-traumatic changes, and these are some of the regions. What you also see is that we have these localized lucencies here in the bone, which are in fact a little bit showing some osteopenia. Also the cortex here has these lucencies. So there is some osteopenia in both hands. What else can you see? You see that if you follow the soft tissues here, you see that there is almost no soft tissues at the distal tip of the finger. So we know already this is a patient with acral necrosis and dense skin. So I don't have a photo here of these fingers, but they can be just like very hard. The skin can be very hard, but it could also be that this is already black. So here we see this small indentation, which could be a hint that this is already a black tip of the finger. Sometimes it's bluish. And so this is a decreased soft tissue mantle. And also if you compare the distal aspects of the bone, so you see at the base, you see the nail process, and you see how long it is, maybe 1.5 centimeters or longer. And this is shorter here, despite the flexion deformity. Also here, it's shorter than it should. So there is also some bone loss already. And what you can see here on the thumb is some soft tissue calcification. It follows the course of the flexor tendon of the thumb, but you need to search in all the joints to see if there are some calcifications, because they can be next to the joint, they can be in the tendon, and then they can be in the acral positions. So this question that I had here, what are the findings? And you could tick those. So the flexion deformities we could see the diffuse demineralization, we could see the atrophy of the acral soft tissues, and also soft tissue calcifications. So these are the 4 correct answers. The erosions were not evident here in this patient. And osteophytes, of course, they are not part of the game in systemic scleroderma. They can occur maybe after long-standing disease with secondary osteoarthrosis, but they are not described in scleroderma, and erosions are only described in about 20% of cases. So erosions are really something rare in scleroderma, but they are not excluding the disease. Okay, and so I think some of radiologists see not a single case of scleroderma in their life, and we here see it maybe at least 3 or 4 times a month, because in our hospital we have a very focused rheumatology department with a lot of patients treated for scleroderma, so we see these changes a lot. So what else do we have? Patient also had calcifications at the elbow joint. So you can see, if you compare it with the thumb, you see here it is like maybe it's better to be seen here. You see that it's like, yeah, it is linear in shape, maybe a little bit of bulging. Here it's all circular and bulging, so it depends also a little bit on the underlying tissue, how it is presenting. And these changes in this configuration could, for instance, also happen in chronic renal disease with deposits in certain tissues. So this is a patient with calcifications in the elbow. We have here the hip, which shows very severe deposits in the muscles in between the muscle structures. We see it also here surrounding the hip joint. And if we look at the chest X-ray, of course, patients with scleroderma, they can have problems with the lung. They get reticular pattern and chronic fibrosis. But here, the reason for this X-ray was the calcification at the shoulder joints that you can see on both sides, and also at the soft tissues in the neck. You can see it. So quite a nice case, and I see Imran studying it. So I guess, are you connected to some rheumatology department in any of your hospitals you're working with?
My work is very general radiology, so we do work with rheumatologists, but I don't get cases like this. This is quite an impressive case. The neck calcifications. What causes the neck calcifications there?
So so this patient had calcifications in all the interstitial tissues. So I think the reason for these calcifications is the same than here. So they just manifest everywhere.
Wow. Yeah. Okay. Yeah. That's amazing. Thank you for that case.
So those of you who want to follow up can read these learning texts later on. Okay, any questions so far? I don't see them, so I will continue. Here we have another one. It's a 50-year-old woman with severe pain. No, not severe pain, with diffuse pain in the finger joints, and she presents to the rheumatology department. She has, the pain has been present for the course of the last 6 months. The main focus of the complaints are the MCP joints. And when she was here, there was no painful joint at all, and also no swollen joints. So we will have a look on what we can see in this pair of X-rays. So we see here the left hand, the right hand, and you see I already have two questions here prepared now. So with a little bit of luck, we could get one answer, because I see now one of you have made the challenge to go into the platform. So what we have here some the joints, the bones look good. We have the cortex, we have the spongious bone, we see the joint spaces, they look very nice. Also on the other side, we can see the carpal bones, they look good. The ulnar has a good configuration, is not longer than the radius, which is always good because there's no mechanical trouble to be expected from this configuration. And of course, we are looking at all the joints, and you could enter which finger shows a pathological finding. And I'm not sure whether this was already done by the one person going into the system. We already have 2 persons answering, and here there was ring finger and D4 left, which is both correct. So we in fact have here some change, which is not here. So the next question is, of course, what is it? And I listed 5 different options, and let's see how these 2 or 3 people have done it. So just one answer is in, so we wait some seconds until we will reveal what it is really. So 5, 4, 3, 2, 1, 0. Okay, let's see. Osteoma. No, it's not an osteoma. It is an osteoma. Would be very dense. And at the distal tip of the finger, it would also have a different name. So the correct answer is Enchondroma. The Enchondroma usually affects fingers, the metacarpals, and the phalanges. Occasionally, it can also be in the distal tip of the end phalanx. And I cannot enlarge it more than this one, but you can see there are some smaller calcifications inside this lesion. And also you see the cortex, which has here this thickness is thinned. So this is a small enchondroma in the tip of the 4th finger, and all the pain has no correlation here, no correlate. So what are the other changes? So acro-osteolysis we have already seen in the second case with scleroderma. So these decreased acral changes are called acro-osteolysis. Tophus, of course, could be tophus. That would be a good answer, in fact, because a tophus would look similar. Then enchondroma is the correct answer. Osteoma is something very dense, which is not the case here. And the Einhorn syndrome, or I don't know how to pronounce it, it has a Latin name of dactylosis spontanea, is a very rare syndrome which causes a detachment of the distal tip of the finger from the base due to some soft tissue ring-like changes, and it is very rare, and it's described in older textbooks, but I've never seen it myself. Maybe Imran has seen it. No, have you ever heard of it even?
No, not really. No.
Okay.
Yeah, that's why I didn't put it down.
Okay. Okay, so this is the case number 3, Enchondroma, as a typical don't touch me lesion, as a typical incidental finding, has nothing to do with the actual complaints. So going further to case number 4. Are there questions? No, there are no questions. There are some. Yeah, okay. Okay, case number 4 is also a patient with pain at the 5th finger, and we will reveal the medical history. It's a 33-year-old woman with pain she presents at the emergency department with painful swelling on the left hand, and as she has told the doctor, she performed some cleaning at home or with some twist, and then there was some pain later on, not immediately. And she's also reporting of occasional problems with swallowing, and also while she's taking a deep breath, sometimes there's also pain in the thorax. And she has difficulty stretching her fingers to fully extend these fingers. So this is an interesting history. And this is, of course, interesting X-rays that you can see. We did only X-rays of the left hand. So this is already a hint. So if our department is taking just one X-ray of one hand, this is probably nothing to do with rheumatology. But let's see what you can see. So which pathological findings are there? You have 5 options. You can tick more than one, but you can also tick just one. So we have ulnar plus, we have erosions, osteoma, acro-osteosclerosis, whatever that is, and fracture. So we have 4 answers. Now it's going. Let's see it. We have all of you answer the correctly. We have acro-osteosclerosis and a fracture, of course. So we have these bright spots. These have nothing to do with the acute medical history. We have this gap here in the cortex of the base of the basal phalanx. So that's a fracture that maybe was due to this twisting movement and needs to be taken care of, maybe in conservatively measures. And these dense tips of the distal fingers, they can occur in scleroderma again, but they also can occur as a harmless side finding. So this medical history has shown some hints on how patients with scleroderma are affected. So they have sometimes swallowing problems. That means the esophagus gets slowed by like collagen deposits in the esophagus. There's slow swallowing, so patients have problems swallowing, and also they get an interstitial pneumonia, chronic fibrosis of the lung. So on deep inspiration, they can sometimes feel it, and also the rheumatologists, they can listen to the lung and say it's sclerodermic sounds coming from the lung. And of course, if patients cannot stretch their fingers, you should also be careful about scleroderma. So it's a patient of scleroderma. Again, you can read about the two findings that we found here. The other causes, so ulnar plus. I don't think that this is ulnar plus. That's more or less perfect. And if you look at the oblique view, of course, then the ulnar is a bit more to the distal aspect than here, but you should always judge it on the PA view and not on the oblique ones. Next case. Any questions so far? I see 2 comments. No, I don't see any comments. No. Oh, yeah. People are responding, which is very good. And I will continue with, we have an international audience. I see people from Colombia, not Colombia in USA, but Colombia in South America. And no, very nice. So we have this case. And of course, now we are leaving the X-ray only motto for today's evening. We have this patient of a 60-year-old male, long-standing swelling with pain at the hand and the feet, and especially the big toe. We have the photo of the big toe here. And DMARD therapy did not control the changes. So there are also solid nodules, and rheumatoid factor is negative. So we do not know about other lab tests, but I would think that also Dr. Imran would be very curious about one specific lab test in this case.
Yeah, the uric acid, isn't it?
Yes, in fact. So we have this deformity here. And the first question is if you can already make a diagnosis just by the photo and the history, and all of you say it's gout, so that's very, very nice. So the patient was followed up 1 year later. The uric acid was intermittently elevated, also CRP, and this is now the result. We have the X-ray now of the foot, and you can see that if there are very distinctive findings of gout. So we have this swelling here and here. So this is the interphalangeal joint. This is the metatarsophalangeal joint. And we have this swelling here, bulging out, and also here. And if you look carefully, you can see that this swelling produces some destruction over here. It's like pressure, like a pressure on the bone. So it is not, in fact, like in rheumatoid arthritis, where you have synovitis inside the joint capsule, and then you have the destruction of the bone inside the joint area, where you have the marginal erosions coming from all the sides. Here it's like it's something outside of the joint and it's pressuring on the bone, and if it's long standing, the bone gets away and gets atrophic. And also we have these periosteal reactions that you can see here. You see it here, but this is, I think, the best example. I don't know if you can see it in the live stream. This is a so-called gouty periosteal reaction or gouty spike. And this is very pathognomonic for gout deposits. Also, you see here the dense area. So you don't need a dual energy CT here in order to make the diagnosis, because it's very typical based on X-rays. You see the dense deposits here. They don't have any particular punctuate calcifications, but you can see these deposits already. We can check on the other joints, but they look good. Okay, the question was, what would you say? Of course, this is not easy because I told it already. It's gout. And I think one of you was tricked by the periosteal ossifications, because in psoriasis, periosteal ossifications are the main finding. And here, these periosteal changes, they could, maybe these one, they could also happen in psoriatic arthritis, maybe the spike not, and also in combination with this soft tissue lump. That's not a typical finding. Okay, looking at the CT, that's a standard CT, because every dual energy CT also brings a standard CT. So we have here this destruction. We see the large erosion over here, and we also see the dense material, which we could not appreciate nicely here because we did not see the single calcifications, which we can see now. And of course, if we do a dual energy CT, it all shows up in color. And depending on which manufacturer you're trusting, it's either red or green. Okay, any questions so far to this case, our 5th case? We have some minutes left. And to be honest, the 6th case, I don't have a good medical history, and it is really difficult to decide what's happening here. We can do it together. Also, this was a teaser image of this show. So in fact, I took an image where I was not fully clear what it is at the end. So it's a young woman, 28 years of age, very young. And she has deformities in both hands, which we can see already. And also partly she reports of Raynaud's phenomenon. So that is maybe a good clue. If we look here, so that is the AP view, that's maybe the obliques. And if we look here at the fingers, we see there are some erosions. Also here maybe. These two joints, maybe also here are some erosions, maybe here. And there's, of course, ulnar deformity, so it's connecting to the first case of our session today. And we have problems extending the finger. We have even severe flexion deformity of the 5th finger over here. So this picture could be arthritis mutilans that we see in psoriatic arthritis. And it could be again, Scleroderma, because then there is increased collagen tissue. The finger is brought down due to the skin, which is very dense and cannot be extended. So in the first case, I said erosions can happen in 20% of cases. So that would not exclude Scleroderma. For psoriatic arthritis, we would expect periosteal reaction. And unfortunately, this patient has periosteal reaction. If we look here, we see there's a little bit of positive finding here, but especially on the right side, we see very severe, dense areas, and also maybe here. And we don't see any soft tissue calcifications at all at the fingers. So here, there's the acros look good, and also there's no acro-osteolysis. And that, I think, makes this case so difficult. We can have a look at the feet. So at the feet, yeah, I don't see much. Don't see calcification. Maybe the dense nail, which is showing up here. And of course, due to the deformity, we have also some deformities here of the metatarsus. So in fact, it could be Scleroderma and psoriatic arthritis, but not rheumatoid arthritis. And I think there are some ideas about lupus. Some ideas about lupus from many of you. And there is one deformity typical for lupus that is called Jaccoud arthritis. Jaccoud, I type it in, Jaccoud arthritis. Don't know if I can bring it up. Yeah, Jaccoud arthritis. And Jaccoud arthritis usually is described in older textbooks related to rheumatic fever, which is a disease of the heart that can lead to severe changes. And a similar arthritis is also described in lupus, and they took the same name, but the original description was in rheumatic fever. But Jaccoud arthritis is a feature of lupus. So in fact, Jaccoud arthritis would be a third option. So I would go for Scleroderma here because of this Raynaud's phenomenon. Yeah, of course, lupus patients can also have Raynaud's, and sometimes in rheumatoid arthritis you have a Raynaud's phenomenon as a prodromal stadium. So this is really difficult, but I think the patient was treated as a Scleroderma in our department, but I don't remember very well. But you see, sometimes it's not easy. It's sometimes not easy. So any questions so far from your side? I want to take the opportunity to show you the option to learn with the BerlinCaseViewer database. So you see, I'm making these live streams from time to time, but you can also go in and learn whenever you're ready. So similar to the discussion forum in radiology seminars and the fellowships, we have our online academy. And this online academy was initially published in October last year. So as some of you know, we are having the apps for the Mac, for iOS and for Android. And we could not work with people who are working on a Windows machine, also wanting to get this access purchased by their employee, by their hospital administration. So we set up this web-based version, and we have three options: the free modules that are usually like introductory modules, or sometimes like random case collections. We also have some cardiothoracic options. For instance, we have our free learning material on COVID pneumonia. Today it's not working. It's not working here because I'm in the same browser. And we also have the educational plan where we have mainly stuff that is interesting for radiographers and students. And then we have also the full plan where we bring out all our knowledge about rheumatology diseases, and also trying to be very inclusive, bringing a lot of stuff for all fields of musculoskeletal radiology. And I can only warmly recommend to to try it out at least 1 month or so to see if it's worthwhile. And I would be happy to see some of you in our online academy. So Imran, how did you like our cases today?
Challenging. Yeah, really, really good. I genuinely enjoyed it. You're a very, very good teacher. I really, really enjoyed it a lot, actually. So thank you so much.
Yeah, thank you. I wanted to make it challenging also because X-rays, sometimes they have this old-fashioned feel. People don't like to report them, and they want to go to the MRI department to see what's going on there and skip the X-ray. But I think X-rays can be very rewarding when you do the diagnosis. And of course, these changes with these small periostal reactions, you cannot see them on the MRI. You see them indirectly, maybe if you are lucky, if you have a good quality MRI, if you have an MRI with contrast agent and a good coil, etc. But sometimes you don't have that. So thank you, Etienne, for saying thank you. Thank you, Imani, for being here. You are always here. I appreciate it a lot. And thank you, Imran, for staying here. Thank you, Asif, I bring you on stage, for helping. And thank you all for spending this evening with me, and see you at the next time. Bye-bye.
Okay, bye.